For decades, when the delicate tissues of the pelvic floor failed, surgeons basically just relied on synthetic plastic meshes to hold everything together.
Right, the polypropylene mesh, which seemed like a good idea at the time.
Yeah, but for thousands of women, their bodies fiercely rejected those synthetic implants. It was a disaster, but what if the ultimate surgical mesh isn't manufactured in a factory, but is actually already flowing through your veins right now?
I mean, it sounds almost like science fiction, right? Suggests we could just weave a new structural support out of your own blood. But it is the reality of modern regenerative medicine.
It's totally wild.
It is. We are finally figuring out how to isolate the body's inherent blueprints for tissue repair and deploy them exactly where they're needed most.
And deploying them is exactly what we are unpacking today. So welcome to this deep dive. I'm your host, and today we're wading through a stack of medical journals, clinical protocols, and surgical research.
Lots of dense reading for this one.
Oh, for sure. But we're tackling a highly specific, cutting-edge mission today, which is, can an autologous platelet-rich fibrin matrix, often called PRFB, combined with fluid PRP to create a sustained release scaffold in the anterior vaginal wall?
And, I get that the focus might sound incredibly specialized, but the stakes for you as a listener couldn't be higher. Pelvic floor disorders, things like pelvic organ prolapse, stress urinary incontinence.
Yeah, super common issues.
Massively common.
Yeah.
And even severe complications like vesicovaginal fistulas, they can completely derail a woman's quality of life.
Absolutely.
And for a long time, as you mentioned, the surgical gold standard was that synthetic polypropylene mesh. But the medical community learned a really hard lesson there.
Because those synthetic implants carry some severe risks of adverse effects, right?
Exactly. We're talking chronic inflammation, severe foreign body reactions where the immune system is just constantly attacking the plastic, and agonizing mesh exposure as it literally erodes through the vaginal wall.
Ouch. Yeah, so the race has been on to find a biological alternative, basically the holy grail of urogynecology.
Right. Finding a way to rebuild those delicate structures using the body's own materials with zero synthetics involved.
But, to get to how we rebuild the pelvic floor, we first have to wade through a bit of medical alphabet soup.
Oh, yeah. The acronyms.
Right, PRP, PRF. They sound nearly identical, but the sources heavily emphasize that they are fundamentally different biological tools.
They absolutely are, even though they share the exact same origin point. Both of them are autologous platelet concentrates.
Which means?
Which just means we draw a small sample of your own blood. There's zero risk of rejection because it's your unique DNA.
Right, it's your own stuff.
Exactly. And both therapies rely heavily on platelets, which most of us just think of as those, sticky little cellular fragments that plug a leak and stop the bleeding when you get a paper cut.
Right, but they are doing way more than just clotting. The sources describe platelets as these, tiny cargo ships.
I love that analogy.
Yeah, inside them, they carry structures called alpha granules, which are basically bursting with growth factors. And this is where we have to break down some of that jargon, because the research mentions things like VGF, PDGF, TGF-beta.
Well, we can definitely decode those, because those growth factors are essentially the chemical messengers that tell your body's construction workers to get to the site of an injury.
Okay, so like a 911 dispatch?
Exactly. So VEGF, for instance, is vascular endothelial growth factor. That is literally the specific protein that commands your body to build brand new blood vessels from scratch.
Oh, wow.
Yeah, it triggers a process called angiogenesis.
Which you obviously need if you want to bring oxygen and nutrients to a healing tissue.
Right. And then you have PDGF, platelet-derived growth factor, which calls in the fibroblasts.
The fibroblasts, those are the cells that manufacture new collagen, right?
You got it. Plus TGF-beta, transforming growth factor, which regulates that whole inflammatory and repair process. So the ultimate goal of these blood therapies is simply to concentrate those messengers and drop them right onto an injury.
The catch, though, is that how we process your blood completely changes how those growth factors behave in the tissue.
Oh, fundamentally, it dictates the entire timeline of healing. And that whole timeline is controlled by one machine, the centrifuge.
Okay, let's unpack this centrifuge process. Starting with the older of the two, the first-generation therapy, that's PRP, or platelet-rich plasma.
Right.
To make PRP, a doctor draws your blood into a tube, but they add a chemical anticoagulant so the blood doesn't clot.
That's a crucial step.
Yeah. Then they put it in a centrifuge and spin it at a very high speed, usually in a double spin process. This forces the heavy red blood cells to the bottom and leaves the plasma and platelets suspended at the top.
And because of those added anticoagulants, the final product you get is a liquid. It's highly fluid.
Okay.
Now, that fluidity is useful, but it comes with a massive physiological limitation when we're talking about long-term tissue repair.
Because it just washes away.
Basically, yeah. Because it's a liquid, and because of the harsh mechanical forces of that high-speed double spin, PRP releases its payload of growth factors incredibly fast.
Yeah, the sources show nearly 95% of those healing factors are dumped into the local tissue within the first hour.
It's so fast.
The absolute maximum release window is like maybe 1 to 2 days.
It's an immediate, massive spike, and then the supply is completely exhausted.
It's kind of like pouring liquid fertilizer on a dying lawn. You get this huge, intense wash of nutrients, which stimulates things initially, but a lot of it just washes right past the roots into the surrounding dirt.
That is a highly accurate way to look at it.
It's a flash flood of healing.
A flash flood, exactly. And observing that flash flood effect is what led researchers to hunt for a second-generation advancement.
Because complex injuries need more time.
Right. Healing complex tissues takes weeks, not hours. So they had to figure out, how do we artificially recreate a slow, sustained release? And that brought us to PRF, platelet-rich fibrin.
And the preparation for PRF is surprisingly simpler, actually. You draw the blood into a tube, but you add absolutely no anticoagulants. 0 chemicals.
Nothing but blood.
Right. And you spin it much slower, just a single gentle spin.
And without those chemical additives, the blood does exactly what it's biologically programmed to do. It begins the clotting cascade right there inside the tube.
But it's spinning at the same time.
Right. Because it is simultaneously spinning at a low speed, the components of the blood are gently separating while that clot is forming.
So the plasma contains a protein called fibrinogen, right? And during this slow spin, it converts into insoluble fibrin. It basically weaves itself into a 3-dimensional matrix.
Exactly. It's not a liquid anymore. It
Yeah.
forms an actual physical gel-like scaffold.
And this is where the cellular magic happens. As that 3D fibrin net is weaving itself together in the tube, it traps the platelets inside its physical structure.
But it doesn't just trap platelets. The gentle spin preserves leukocytes. Those are your white blood cells, which are crucial for immune modulation and clearing away dead tissue.
Oh, that's amazing.
Yeah, it even traps circulating stem cells.
Because all of those cells are physically bound inside that 3D net, they simply cannot dump their growth factors in an hour. They are locked in.
Right, they're physically restrained.
So instead of liquid fertilizer, PRF is more like laying down a layer of nutrient-rich topsoil. It provides physical structure, and as that fibrin scaffold slowly degrades in the body over 7 to 15 days, it continuously releases those growth factors in a slow, sustained physiological drip.
Yeah, you are mimicking the natural biological timing of wound healing. You're giving the tissue a sustained feeding schedule over 2 weeks.
Right when it needs it most.
Exactly. Exactly when the body's repair mechanisms need that constant signaling to keep working.
Okay, I have to push back here for a second, though. If PRF lasts a full 2 weeks, has a physical scaffold, holds white blood cells, and mimics the natural healing timeline so much better, is liquid PRP just obsolete?
Oh, I see where you're going.
I mean, why wouldn't a surgeon just use this 3D gel for absolutely everything?
Well, it comes down to the fundamental mechanics of the injury you're treating. You always have to match the physical properties of the biological tool to the anatomical environment.
Okay, that makes sense.
So PRP is definitely not obsolete because it remains a liquid. It's an incredible broad dispersal fluid. Think about orthopedics, like an arthritic knee.
Ah, right. You wouldn't want a solid gel matrix jamming up the gears inside a joint capsule that needs to bend and glide thousands of times a day.
Precisely. You want a lubricating wash. Injecting liquid PRP into a joint space provides that smooth fluid dynamic alongside a massive, immediate shock of growth factors.
So it jumpstarts the process.
Yeah, sometimes a dormant chronic injury has essentially stalled out, and it needs that violent flash flood to shock the cellular environment back into an active inflammatory healing phase.
Okay, so if liquid PRP is great for joints because it disperses and lubricates, what happens when we try to use it on tissues that don't need lubrication, but actually need heavy structural support?
Now we are getting to the core of the issue.
Which brings us perfectly to the pelvic floor, specifically the anterior vaginal wall.
Right, the anterior vaginal wall is essentially a vital structural hammock. Its primary job is to hold up the bladder, the urethra, and other heavy pelvic organs.
It's doing a lot of heavy lifting.
It really is. It consists of the vaginal mucosa and a tough, fibrous layer called the pubocervical fascia.
But that hammock takes a beating over a lifetime. The forces of childbirth, the loss of estrogen during menopause, chronic coughing, or just the natural aging process can cause those fascial tissues to stretch, thin out, or literally tear.
And when that structural integrity fails, gravity wins.
Gravity always wins.
Unfortunately, yeah. The bladder can bulge down into the vaginal canal, which is a pelvic organ prolapse. Or the weakening of the support around the urethra leads to stress urinary incontinence, where, just coughing or laughing causes urine leakage.
And the sources also talk about something even more severe, which is recurrent vesicovaginal fistulas.
Yeah, a fistula is an abnormal anatomical connection. It's essentially a hole that has formed between the bladder and the vaginal wall. Urine continuously leaks through this defect.
That sounds awful.
It is. And it is notoriously difficult to repair surgically because the surrounding tissue is often heavily scarred, poorly vascularized, and lacking the cellular vitality to actually heal a surgical closure.
So the urogynecology field, trying to move away from those disastrous synthetic plastic meshes we talked about earlier, naturally started experimenting with blood derivatives to heal these defects.
Right, they needed a biological solution.
And they started with liquid PRP. The literature shows PRP actually did some great things for gynecology on a surface level. It increased vaginal vascularity, thickened the mucosal lining, and improved tissue sensitivity.
It acts as an excellent tissue primer. But, and this is a big but, when surgeons attempted to use liquid PRP to physically reinforce structural repairs, they hit a wall.
There is a very specific study detailed in the sources that illustrates this perfectly.
The 10-milliliter study.
Yes. Surgeons took 10 milliliters of liquid PRP and injected it straight into the pubocervical fascia, that structural connective tissue, during an anterior colporrhaphy, which is a major prolapse repair surgery.
Right, they were hoping the growth factors would stimulate a massive wave of new collagen to really strengthen the repair.
But when they performed biopsies at the 3-month follow-up, the results were deeply disappointing.
They really were.
There was absolutely no significant increase in the collagen content of the fascial tissue. The physical repair wasn't any stronger or more durable than a standard surgery without PRP.
And based on everything we just discussed about centrifuges, it makes total sense why it failed. The liquid PRP simply dumped its payload and washed away.
Right. Going back to the hammock analogy, if you have a frayed, tearing hammock under tension or a literal hole like a fistula, pouring liquid fertilizer on it doesn't patch the hole.
No, it doesn't.
The growth factors just dissipate into the surrounding tissue before they can induce the dense architectural remodeling that a structural defect requires.
You need something for the cells to actually hold on to. Healing a structural void requires a physical highway. And that realization led a different group of researchers, led by a doctor named Gorlero, to try a totally different approach.
Okay, here we go.
They abandoned the liquid PRP and utilized an autologous PRF matrix.
The gel! And the stakes in this Gorlero study were incredibly high. They didn't just take average patients. They took 10 women who were suffering from recurrent pelvic organ prolapse.
Recurrent being the key word there.
Meaning these women had already undergone traditional repair surgeries and their bodies had failed again. Their native connective tissue was already exhausted, scarred, and severely degraded.
It was a very tough baseline.
Yeah.
So the surgical team prepared the PRF matrix, generating that thick fibrin scaffold, and utilized it as a sprayed graft material directly over the structural repair site.
And the outcomes compared to the PRP study were staggering. After following these women for 24 months, the study showed an 80% anatomical success rate.
Which is huge for recurrent prolapse.
Huge. And even more importantly for you, the patient, 100% of the women reported complete symptom relief. They even noted that sexual activity returned without any painful intercourse, which, as we mentioned, is a tragically common side effect of rigid synthetic meshes.
To understand why the PRF succeeded where the PRP failed, we really have to look at the micromechanics of cellular healing.
Okay, break it down for us.
So fibroblasts, those collagen-producing factories we talked about earlier, they cannot just float across a structural void. They physically need a scaffold to grab onto and crawl across.
It's like building a bridge. You can't just throw wet concrete into the middle of a river and hope it spans the gap.
Exactly.
You have to lay down steel rebar first so the concrete has something to cling to and harden around.
That's a perfect analogy.
Yeah.
The PRF matrix acts as that biological rebar. When the surgeons place the PRF graft over the prolapse repair, they physically bridge the gap in the degraded fascia.
Creating a path.
Right. The dense fibrin network gave the fibroblasts a solid molecular highway to travel across.
And because it's a slow-release system, as those fibroblasts are crawling across the fibrin highway over 14 days, the PRF is constantly feeding them the exact localized growth factors they need, the PDGF and TGF-beta.
Right, to lay down new, highly resilient connective tissue.
And then the PRF eventually dissolves completely, leaving behind a rebuilt biological support wall constructed entirely by the patient's own cells.
You've essentially tricked the body into replacing a synthetic plastic mesh with a temporary, highly bioactive mesh made from a simple blood draw.
It's brilliant. Which brings us to the ultimate question, the exact mission of this deep dive. If PRP offers an incredible immediate vascular kickstart and lubrication, and PRF provides this magnificent physical scaffold that drips growth factors for 2 weeks,
Right.
what happens if we combine them? Can we put both in the anterior vaginal wall?
Yes. It's a realization that regenerative healing isn't just about throwing a bunch of ingredients at a surgical site. It's about geography and timing.
Okay, geography and timing.
We don't have to choose between the flash flood and the topsoil. Advanced clinical protocols are now actively using what they call targeted layering, or a hybrid approach.
So how does a surgeon actually orchestrate that geography and timing in the operating room?
We are artificially recreating the exact spatial timeline of natural wound healing, but amplifying it. In a complex reconstruction of the anterior vaginal wall, the surgeon applies the solid PRF matrix directly to the primary structural defect.
So right in the middle of the damage?
Exactly. If they are fixing a prolapse or patching a fistula, the PRF is the central structural graft. Its dense fiber network physically stabilizes that weakened fascia.
Got it.
It mimics a natural biological membrane, holding the fort, immune modulating the space with white blood cells, and guiding that fibroblast migration for a full 2 weeks.
So the PRS is building the house, but what about the neighborhood?
That's where the fluid PRP comes in. While the solid PRF scaffold is doing the heavy lifting in the center, the surgeon injects the liquid PRP into the surrounding submucosa, the adjacent mucosal layers, and the fascial margins.
Because it's a fluid, it easily infiltrates all the neighboring tissue. It just bathes the entire surgical microenvironment.
Exactly. It provides that immediate, intense burst of VEGF to instantly kickstart angiogenesis. It wakes up all the surrounding dormant cells, flooding the zone with anti-inflammatory signals.
Preparing the ground, basically.
Yes, essentially priming the entire anatomical neighborhood to support the heady construction happening in the center.
But wait, if you mix a liquid and a solid in the same anatomical space, doesn't the liquid just dissolve or wash away the scaffold? Doesn't the massive influx of PRP fluid dilute that carefully constructed 3D fibrin matrix we worked so hard to spin at a slow speed?
It's a very logical mechanical concern, and it's exactly why the term is targeted layering.
Ah, targeted.
Right? They aren't just mixed together in a bowl and slathered on. The solid PRF graft is sutured or adhered to a specific depth, the structural fascial layer. The liquid PRP is injected into adjacent zones, the shallower submucosa or the peripheral margin.
Oh, I see.
The liquid doesn't wash away the solid because they are purposefully applied to different tissue layers that support one another.
It's true cellular synergy.
It really is. You get the immediate pain relief, the rapid anti-inflammatory action, and the aggressive vascular kickstart of the PRP, perfectly paired with the long-term structural scaffolding of the PRF.
The best of both worlds.
It ensures the whole microenvironment is biologically optimized to heal without ever compromising the physical integrity of that central fibrin matrix.
That is just phenomenal. So to synthesize this entire journey for you listening, we started by looking at a simple tube of your own blood spinning in a centrifuge. We learned that the speed of that spin dictates the architecture of the medicine.
Right, speed changes everything.
Spin it fast with chemicals, and you get PRP, a rapid burst liquid that acts like a flash flood of healing factors, excellent for broad dispersal and waking up dormant tissue.
Yep.
Spin it slowly without additives, and the blood naturally weaves PRF, a 3D physical scaffold that provides a slow drip of nutrients and a molecular highway for cells over several weeks.
And when it comes to something as mechanically complex and vital as the anterior vaginal wall, we're no longer bound to the risks of synthetic plastics.
Right. By utilizing targeted layering, surgeons can deploy the immediate bioactive power of PRP to prime the tissue while laying down the structural endurance of PRF to patch the defect. Together, they offer a personalized, completely autologous solution to rebuild the body's natural support systems using nothing but the patient's own biology.
And that leaves us with a rather profound question to walk away with today.
Lay it on us.
If we can manipulate our own blood, simply by slightly changing the RPMs of a centrifuge to create both immediate liquid healing serums and solid time-release architectural meshes for our most delicate pelvic tissues.
Yeah.
What other failing, degraded structures in the human body could we rebuild tomorrow just by unlocking the blueprints already flowing through our veins today?
Wow, it really reframes how we look at our own bodies. The ultimate medical advancement might just be you. Thank you for joining us on this deep dive. Keep questioning, keep learning, and we'll see you next time.